Evening, everyone, and on behalf of Wave, welcome to Wave Lens Design with Dr. Mahler, Episode 6, for diopter myopic ortho K, what could go wrong? Before we get started, I'd like to remind you all that you can go ahead and ask questions by entering them into your chat box at any time throughout the presentation. We'll only be answering questions directly about tonight's presentation, but we do appreciate any and all questions, and those questions may be the subject of future content presented by Dr. Mahler. On that note, Dr. Mahler, take it away.
Good evening, all, and thanks for coming out to webinar 6 for diopter myopic ortho K. What could go wrong? I think it's going to be an interesting topic because a lot of orthokeratology doctors, especially in their earlier portion of development, are very, very hung up on the prescription as the main criteria for whether or not a case will be easy or difficult and whether they should take it on or not. And for diopter myope is certainly in the sort of the middle of the wheelhouse, I think, that the average ortho K-doc would feel pretty comfortable with. And so I thought this was a very, very good topic to go over with that I'm going to cover tonight. So let's move on here. Let's see if my screen will advance. Okay. In the introduction here, to disclose, I am a consultant for both Oculus and for Wave. I am in private practice. It's a solo contact lens only practice, and it's pretty much focused on irregular corneas. Anyone who doesn't have an irregular cornea is pretty much an ortho K. I've previously done the national clinical support for Wave, and I've also done formal lectures and webinars for Wave users, just like I am doing here tonight. I do offer private practitioner consultation services for Wave doctors, and those take a couple of different avenues of help, and I will post that up at the end of this session tonight. I do beta testing as well, and currently am doing for both the CSP Wave and the AXL Wave hardware. I did author the first certified Wave designing program to get people up to speed, and I am guiding the Wave training currently. All right, this is the webinar schedule that we've got proposed for the next few months. Tonight, of course, is the for diopter myopic ortho K. Next month, we're going to be doing troubleshooting myopic ortho K. It's really best done before starting the case. In May, we're going to look at corneal GPs, because I think corneal GPs tend to get lost for the more exciting, sexier type of designs. And then we'll follow that up in June with corneal GP multifocal, so we can take care of the presbyopes out there. All right, let's get started. This here is a case presentation, and the format's going to pretty much be centered all around this one case presentation, where I'm going to highlight all the various important points of this particular case. So this was a 50-year-old female, and it was sent in to me through private consultation. This case was actually a case that I had done quite a number of years ago, probably 15 plus years ago or so, but it is a fantastic case to really learn a lot of information from. The patient had interest in ortho K. So this case actually started about 2 months prior to the consult with me. The doctor took on the case by himself, and the refraction was -375, -150, axis 160, and a -3 1/4, -150, axis 20. And I think we'd all agree that's a very, very good place to be, sort of in the middle of the bell curve for orthokeratology services. Very regular with the rule type of cylinder, and certainly not very high on the myopia. The doctor had taken keratometry readings, and the keratometry readings, you can see we had 1 3/4 diopters of cylinder in the right eye and 1 1/2 in the left eye. Very, very average type of cornea. And he targeted the full distance correction in each eye. He wasn't really concerned about dealing with reading. This particular patient was fine to use reading glasses, but wanted the distance taken care of. So these were the initial topographies that were taken by that doctor, and nothing very, very unusual about that. but we will get a little more into those a little bit further into the webinar. The simulated Ks you can see are fairly in agreement with his keratometry readings from the manual keratometer. Again, very average type of cornea. The patient was fit into CRT because he had a CRT fit. And so you can see the base on both lenses was at 870. We won't get into the other parameters there for right now. And this was the 2-day treatment for the CRT. And we can see that it's not looking all that pretty. The maps centrally are fairly irregular, as well as we can see the lens is not really landing down properly on this. And so the acuity kind of matched along with these topographies at 2100 and 2080 uncorrected. The refraction that he got that day still showed a fair amount of minus and some cylinder. And he did check the over refraction over the lenses to make certain that he was in the right relationship with that lens design, and he did get a +1/4, so he knew that he felt trustworthy about the data that he had collected. Keratometry, we can see it has been reduced, but certainly looking at the topography, that's not a pretty treatment. So we went for 7 days, and here's the 7-day treatment, and the 2-day treatment doesn't look a whole lot different than the 7-day treatment. So the lesson to be learned from this is bad treatment doesn't improve with time. We had plenty of problems showing up on the 2-day treatment, but he went ahead and let the patient continue for 7 days, figuring he would get better. Of course, it did not. Still, he was a trooper, so he continued and went for the 14 days with the CRT. He didn't even take the uncorrected acuities because I guess she couldn't see anything. The refraction was a little bit less minus. The keratometry was about the same as it was before, but he didn't even send topography. And so at that point, he bailed on the CRT design and decided to do wave lenses based on the original topography. So he went back to the original topography and he went ahead and designed up a new pair of wave lenses. Now, although this case was done many years ago, I have brought this all up to date with the new wave interface. I know for some of you this will be very new and a little bit unsettling as to where all the information is. But as you start to look at these screens, you'll start to become more and more familiar with them. So you can see the right eye on the top and the left eye on the bottom. The diameter measured off the topography was about 11.5 horizontally, and he had chosen 10.6 millimeter diameters for this particular pair of lenses. He went for the symmetry or freeform, and many of you who know me and have heard me talk before know that I do not really jump to freeform lenses. I'm a much bigger proponent of dealing with RSIM and GSIM, and if a case warrants freeform, I will certainly go there, but I certainly would not start on a case, especially with the topographies that we just saw, with a freeform design. The base curves he chose were 894 and 896, which was considerably flatter than the CRTs, which were at 870. So that was actually kind of interesting that he had chosen something so flat. And then I just put up the sagittal depth there so we could see that we did have a little bit of increased sagittal depth on the nasal side versus the temporal side of these lenses. 7-day treatment with this particular pair of lenses. VA was not really stellar. It was 2200 and 2060 uncorrected. The refraction didn't do a whole lot better than the CRT here. You could see plenty of minus and some cylinder left over. Keratometry, it's not even quite as flat as the CRT lenses got her, but in fact, we had a flatter base curve on this particular design by quite a bit, yet the keratometry readings showed that the cornea was actually steeper with this design than it had been with the CRT designs. He did not take topography. So he decided, since acuity wasn't all that wonderful at 7 days, he was going to go for the 21-day treatment. So he brought it back 2 weeks later, and we could see the acuity was even worse. We were at 2400 uncorrected in each eye. Refraction, that's actually even a little worse too. We have more cylinder and more minus that's showing up now. So that kind of goes along with the uncorrected refraction. And once again, the keratometry is still showing that it's actually steeper now than it had been with the CRT lenses, which in fact were steeper lenses than these wave lenses. Again, the over-refraction over the lenses was still +1/4, so he did have a correct relationship. So let's take a look at the 21-day treatment. Here's the topography initially, and here's the topography from those wave freeform lenses, and we could see why she's not doing very well. Those are certainly not very pretty maps. They're fairly irregular. The central portion of this cornea is very sloppy looking, and that certainly explains her poor acuity. So why did this case go so poorly? Certainly, it didn't look like it was really out there in terms of a difficult type of a case. But when we look at these corneas, what do we really see? And this goes back to some of the earlier webinars where I said you really have to be very critical of analyzing your original topographies to decide, are you going to get into trouble or not here? And so I put that down over here at the bottom. Let's just take a look. So 2 weeks later, I received this case, and this is what he sent to me. 54 years old. She was wearing spectacles, failed in the CRT, failed with wave. But we do have asymmetric corneas. If you take a look at this map, particularly on the left eye, you'll see that it's considerably steeper in the lower half than it is in the upper half. Or as I had commented in the earlier webinars, that would definitely fail my pen test in terms of symmetry. And so that's certainly a big issue. The right eye is also asymmetric, but it's not quite as asymmetric as the left eye. And the tear quality is questionable, and tear quality is an incredibly important parameter to assess before you take on any Ortho-K case, and especially if you're not doing kids, which typically have healthy, robust tear films, and you're doing adults, tear quality that's questionable can really get you into trouble. All right, so here was the refraction, and again, that's sort of where we had started before. And the patient's pupil was about 3.5 millimeters. And this was my initial pair of lenses, the right on the top and the left on the bottom. And my design choices for this pair of lenses are, I went with a larger diameter to begin with. It's an 11.5 cornea. I put up 11.2 into the diameter of these lenses. I chose GSIM as my initial because although the cornea was asymmetric, I did not think it was terribly asymmetric, and I thought we might be able to get some sort of a decent result with a GSIM lens, but I had it in the back of my mind that that may not work out exactly as I want to. I did design up an oval treatment zone. This is something I came up with probably close to 20 years ago with wave, and the reason I did the oval treatment zone where I set up the red control point at 5.6 and 6.2, and the intermediate control point at 6.2 and 6.8 was to deal with that asymmetry that was on the cornea, to try and get this lens to line up better, land better, so we can have a proper seal off outside the reverse curve, and of course get good central treatment. My sagittal depth, of course, my lens is larger, so my sagittal depth is considerably higher than his was. And you can see there that the nasal and the temporal, where the temporal side is actually the one where you would expect that you would have the need for a larger sagittal depth. In a GSIM lens, they're identical. And then, of course, you can see the superior and inferior, which actually are a little bit higher in sagittal depth, which you would definitely expect to be, because the vertical tends to be requiring a higher sagittal depth of the lens, and especially on a cornea that's got a width rule cylinder, since that would be the steeper meridian. Now, the base curve reported by wave is 908 plus or minus 0.16 and 915 plus or minus 0.20, which again, that's even flatter than where he had his lens. And we can see the actual base curves in proper toric notation is actually 894 by 9.25 from the steep to flat meridian, and the 896 to 936 in the steep to flat meridian. My center thickness was 0.24 and the edge thickness is 0.30, which I did go over in one of the earlier webinars as to why I choose that. All right, so if we summarize, refractively, she has 1¼ diopters of cylinder on the right eye and 1½ diopters on the left eye. The corneal cylinder, however, on the topographies is actually the reverse. She actually has more corneal cylinder on the right eye than she does on the left eye. The lens cylinder that I designed, or that toricity that I put into the base curve, actually followed the refractive cylinder. And so I did the 1¼ diopters on the right and the 150 diopters on the left. Here's my oval treatment zone, the base curve here, and it's better seen if we magnify that quad view. You can see here on the fluorescein map that it's squashed a little top to bottom, and that's because that's my smaller treatment zone versus the horizontal. And that, of course, is the steeper meridian. And then also in the lower right of each of the quad displays there, you can actually see the bow tie representing the the blue, deeper blue vertically for addressing that steeper meridian. And this was all to get a better alignment of this lens so that we can render proper treatment centrally. So 2 weeks after the dispense, this was the first consult that I got to follow up with here. And this was the history. She was wearing a nightwear only, but during the day as well. And the reason was she was having a difficult time functioning through the uncorrected vision. She was comfortable with the lenses, and they appeared to be well centered with a well-defined oval treatment zone when he checked them on her eyes. VA, not very good, 2100 minus and 2200 plus. So again, the uncorrected acuity is pretty poor. Nothing unusual at the biomicroscope, and the topography showed poor maps, and the refraction, certainly we missed the ball on the right eye. We got 2¼ diopters of cylinder there. And then on the left eye, although the minus overall has been reduced, notice that she only gets to 20/50 minus, and it's a poor endpoint. So that indicates probably something irregular going on with the topography. So let's take a look and see what that looks like. So here's the topography of that pair of GSIM lenses that I had designed. And you can see they actually don't look nearly as bad as that initial pair of wave lenses that were done in freeform. So when I take a look at topography treatments for Orthok, this is the triad that I sort of go over in my head mentally. Number one, how's the position of my treatment on this cornea in relation to the limbus as well as to the pupil, the patient's pupil. And we could see here that it probably is just sitting a hair high on the right eye. Left eye is actually not all that bad. The next consideration is that parameter I refer to as homogeneity, meaning that in each of the zones, sort of the central treatment zone, the reverse curve, hot zone, and then the outside landing area, how homogeneous does that look? And we can see on the right eye that the homogeneity of the center is pretty poor. The reverse curve is fair, and the landing area inferiorly isn't bad, but superiorly we have a little bit of that bleed out there up to the superior and superior temporal area there. On the left eye, it's all a little sloppier. We have the very sloppy center. The reverse curve is not really as homogeneous as I'd like to see it. And then the landing area, we definitely have it bleeding both top and bottom outside the reverse curve there. So not very good. And then the last sort of parameter that I really want to check is the crispness, meaning how well defined is each specific zone. And we can see there that it's not really as crisp as I'd like to see it. So what are the actual problems with this particular treatment? So I've put that up in the upper right there. And 2 weeks after the dispense, this is my summary. They're not really as decentered as they appear. That may just be the open eye wearing. The area over the pupil is very irregular, hence the poor vision and the refractive data. And the source of this can be the tear film problem that we talked about right at the beginning, the problem that I described below in item 4, which I'll get to in just a moment, or a combination of both of those. Between the two, the left eye has a much bigger concern. The area vertically outside the red donut is showing poor alignment, and this is actually the heart of the problem and could be coming from two sources. A, the mid-peripheral vertical alignment is just poorly aligned. There's too much clearance there, causing the lens to rock, leading to all of the above, and I would need to redesign the lens in that area. Or the second possibility, the mid-peripheral vertical alignment zone is showing poor alignment because the lens is in fact rocking upon up and down movements when she blinks during her open eye wearing, and she's been wearing these for 3-hour periods during each day. So what we had to do is we had to figure out, why is that lens not aligning properly in that mid-peripheral area just outside the red donut? So this was the plan that I gave him. I told him to apply the lenses in the office, put in some fluorescein, and have her sit with her eyes closed for about 10 minutes. Without opening her eyes, guide her into the scope, and then take a look over the closed eyelids so that everything is lined up. And as soon as he was ready, he was going to have her open her eyes and quickly assess the vertical centration of the right and left lens. That was to see if, in fact, under the closed lid, are the lenses drifting to the center, or are they, in fact, sitting a little bit high? Then carefully assess the sodium fluorescein pattern in that vertical mid-peripheral area outside the reverse curve. If he sees green rather than dark, then we're going to have to estimate how much green is really there. And that's sort of old school fluorescein reading, where you assess base curve steepness by a quarter diopter, half diopter steep, etc., so that we can get an idea of what we need to do to try and get that to align better in that vertical mid-peripheral area. So 2 weeks later, after the dispense, we were summarizing what we needed to do with all this, and based on whatever he was going to find out at that's going to guide how we fix the problem here. If there's no fluorescein vertically, just like the horizontal mid-peripheral area outside that reverse curve zone, then we know the problem's coming from the open eye wearing, and we'll have to deal with that. If the open eye wearing really is the problem, maybe we could supply her with enough vision during the transition period through a soft lens, or maybe we'll do one eye at a time, or maybe make up a pair of glasses or something, but we're going to have to get her to sort of buy into the fact that she cannot wear these lenses during open eye wearing, if in fact that is the problem. And then of course we'll also have to figure out what the tear film's role in is in all this. All right, so a week later he did the in-office trial, and these were his results. Both lenses did ride just slightly high of center, but the sodium fluorescein did appear dark 360 around the reverse curve. The patient agreed that doing one eye at a time would probably be the best way to proceed, and since the left eye was certainly the more problematic eye and it's certainly the more challenging eye, we were going to start with that one first. So I went ahead and we agreed to redesign that left lens to deal with the asymmetry and that inferior mid-peripheral looseness. So here I've put up on the left the original left lens that I did, and on the right is the new left lens with its new changes. And so I've broken them down in a summary here. So we started with GSIM, and I changed that to a freeform. So for those of you who think I don't do freeform, you can see that I actually do when it's warranted. And yes, I did believe that freeform was the way we were going to deal with that asymmetry. Now what I've done here is I put a little red indicator there because this change was done at the red control point. We can see in the 0, 0, 0 semi-meridian, which corresponds to the nasal side of the right lens and the temporal side of the left lens. The power here is plus 148, and the sag is 589. And so what I did was I increased the treatment by a quarter diopter up to about a 175 diopters, and the sag was about 585, which had decreased a little bit there. I changed the power in the 90 from the 307 and the 466 microns of sag to a quarter diopter up, 334, and the sag again about 464, so not a lot of change there. On the 180, the power was at 148, again because it was the same as the 00 since it was a GSIM lens, and with a sag of 589. And here I actually decreased the quarter diopter down to 119. So you can see here, now that it's not a GSIM lens but a freeform lens, I was able to create an asymmetry in the center treatment area here separating those by about a half a diopter. And then, of course, the sag is at 592. And then down at the bottom there, we started at 307, which was, again, the same as it was at 90 in the GSIM lens. But here I did also decrease it a quarter diopter down to 282. And so you can see there, again, we have about a half a diopter difference between the top and the bottom central treatment. And again, of course, the sag now is at 473. So that's actually increased a fair amount. Along the 0, 180, I left the 6.2, 5.6 locations for the red ball. And then the did not make any changes on this new lens, so I kept those locations consistent. At the blue ball, I did make these changes. In 90 and 270, we started at 617 microns, and now you can see I've created a bit of asymmetry out where the landing is by decreasing it in the 90 and increasing the sag down at the 270. And so we have a difference there of almost 15 microns. And then at the pink ball, we could see we started at about 18 and a quarter at both the 90 and the 270. And what I did here, because we do have the ability in the free form to keep those separate, you can see here I have almost 100 microns of difference between the upper portion and the lower portion of this lens. I did make that change in a 50% mode. So if you would take a look at the obliques, they change by half. And then, of course, along the horizontal, I didn't change that at all. So 2 weeks after dispensing the second lens, she was doing only the left lens at nighttime because we convinced her that was incredibly important, but she was wearing the daytime right lens in addition to nighttime as well as she needed it. She was filling the lens with Celluvisc, and she said the comfort of the lens was good. VI on the left eye was 2100, so still not a lot better than it had been before. At the biomicroscope, the left lens centered well, treatment zone centered, but more pooling of fluorescein superior to the pupil. Dark area centrally is a horizontal oval, so that's actually good. Inferiorly, we had some pooling from 5 to 7 peripherally, and then the remainder of the periphery is aligned. Refraction, not very good still, 175 by 175. But it did get her a good endpoint to 20/25 minus, which was about her best corrected there. She was only about a 20/25 eye in that left eye. So let's take a look and see what the topography looks like. Now we can see here, the right eye is not very pretty as we kind of expected, but look at the left eye, how much better this is actually looking. We have a good improvement in terms of the overall treatment, but it's still really not clean enough. That triad that I'm looking for is really, the position's okay, but the homogeneity and the crispness is not really there. So why is she so undercorrected? Well, this was my plan. I want her to continue nightwear only, but I just wanted her to stop using the Celluvisc. Back then I was using Optimum WRW, and so she was only to put that into the bowl of the lens, which is considerably thinner than the Celluvisc. I wanted her to Q-tip the ocular surface of the lens to clean up that lens and then recheck her in a couple of weeks. So she came back 6 weeks after this dispense. And again, nightwear only on the left, but both night and day wear on the right. But she did stop the Celluvisc. She was following the instructions, and she said that the vision seemed a little bit better. Notice our acuity is a little bit better at 20/50 minus. Lens centered well, horizontal treatment zone, it looked good and just as expected. And the topography was really the best thus far. And now look at the refraction. We're down much, much better. It's still got a ways to go, but we're only at a half of minus and 150 on the cylinder, which is where we started. So if we look at the topography, take a look at these. The one on the left is with Celluvisc. The one on the right is the exact same lens, yet it looks a whole lot better without the Celluvisc. Don't kid yourself that what they fill these lenses with does impact how a lens will perform. So we have some uncorrected myopia and cylinder remaining. We still have some mid-peripheral vertical clearance that's in excess, particularly down at the bottom. And the apical area is still a little sloppy, which is why the vision's off a little bit. So we went ahead and made some new changes. There's the left lens that she's wearing on the left side there, and the right side is the new left lens that I was designing for her. And once again, I'm just going to go through these fairly quickly now. At the red ball, you can see I've upped her treatment to deal with the undercorrection of the minus. In the 90, I've also increased the treatment by a considerable amount to deal with that cylinder. On the 180, I increased the treatment another 3/4 of diopter to deal with that undercorrection of minus. And then in the 270, I increased again another diopter to deal with that cylinder that we're finding there. Again, I did not make any changes to the locations of those control points. You could see the sags of the blue ball over here, and for the most part, it's not a lot different there on either one. I just made some subtle changes to get these kind of back to where they were before. And then on the pink ball, you can see here that superiorly, I kept her just about the same, but inferiorly, I increased a little bit more sag because we had that problem with the inferior mid-peripheral excess of clearance there. And so let's take a look. Tear film, oh, I'm sorry. Tear film, we left that alone. And this is an important point to understand. On this third lens here, notice that on the back curvature map, those areas that I have the arrows pointing to are flat. And the reason those are flat is because we're at the lathe limits. And it's important to keep those numbers in mind because you can get some really dicey results once you've reached the lathe limits, which is a absolute curvature no steeper than 3 millimeters and no flatter than 1 meter. Those are absolute limits that the lathe cannot cut anything steeper than 3 millimeters or anything flatter than 1 meter. And so just because you want it doesn't mean, and Wave will let you design past that, doesn't mean that that's what you're actually going to get. So you want to take a look at this back curvature map to really keep tabs on that. Okay, so 2 weeks after the dispense of that, she's nightwear only in the left eye. Q-tipping, just as we explained to her. She's reporting actually the vision's actually pretty good, and it's the best that it's been so far, but she's got a little bit of a shadow. Look at our acuity though. We're now down to 20/30 minus. Nothing unusual at the scope, and it has improved the topography. And if we look here at the refraction, for the first time, we're hovering around plano. We do have a little bit of cylinder left over, but at least spherical equivalent, we're right around plano. And she does have a nice good endpoint of 20/25 minus 2 on this eye. So if we take a look here at the topography, we can now see that with this new design, the one that's on the right there, things are really starting to actually look like a decent treatment here. So much better definition. It's a more circular apex. So that central area is doing fairly well. We still do have that uncorrected cylinder. And there still is a little bit of that mid-peripheral vertical excess clearance. You can still see bleeding out down at the bottom there. And still a little bit sloppy on those definition of zones. So I went back and designed up a new lens. That's the one on the right there, number 4. And we can see there the changes. Again, I'm going to go through these fairly quickly here. I decreased the treatment to deal with the actual refraction that we found along the horizontal. Remember, she was already in the plus zone there. So I decreased treatment there. I increased treatment in the vertical to deal with the cylinder. Once again, the 180, I matched that up to what was going on the 000, so I didn't make any change whatsoever. So you can see on the 000, we're at plus 198, and on the 180, we're at 195, so now they're the same. And then on the 270, I did increase that considerably, and that was to bring it up to where we were in the 90s. So once again, you can see up at 90, we're at 634, and down below, we're at 630. So I made that a little bit more equal, both horizontally and vertically. I did not make any changes to the locations. Again, with the sag, superior, not so much of a change, basically kept that the same. But the inferior, you can see there, I'm trying to get that lined up a little bit better so that this lens lands better outside that reverse curve zone. And again, once again, you can see the changes that I made here at the pink ball, and that's all to get that landing zone better down inferiorly. If we take a look here, after that was dispensed, she's doing fairly well with the left eye and wants to know if we could take care of the right eye. Left eye was 20/40 plus, so about the same as it was before, 30 minus, nothing unusual on the microscope. And topography, absolutely by far the very best it's been, and certainly better than the one from 3 months ago. We can now see that we have a much, much better definition, and you can see the refraction. The only thing that's left there is a half a diopter of minus and a quarter diopter cylinder, and it gives her a nice 20/25 endpoint. So she's just a little under minus now, straight myopia. So I went ahead and designed up a lens to deal with the extra minus that she was manifesting on that left eye, and we can see the right eye from all the day wearing as to what's going on there. So we addressed this with a new lens, and what I told him to do was to have her start wearing, since she's doing so well with the left eye, have her start wearing the right lens only at nighttime, and then recheck her in a month so we can design up a new right lens to see what we actually have to deal with. Here are the changes for the left fifth lens, which is on the right-hand side. And I am going to go through this very quickly because all I did was adjust the powers. You can see the half a diopter of minus in the horizontal and a quarter diopter additional in the vertical to deal with the cylinder that was raining. I really didn't make a whole lot of changes to anything else. I kept all that alone because I was happy with the fit. And she came back 4 months later. So that was a little bit out there. And what happened in all that time was the doctor had never actually dispensed that fifth lens that I had done because the patient was doing well. And he decided to go ahead and try and design up a right lens for her himself, following what I had done with the left eye over the previous couple of months there while we were working with her. And she'd been wearing it for a couple of months. VA, not bad. 20/40 in each eye. Unremarkable, and the topographies are actually quite good. And you can see here, there's a little bit of cylinder there, but for the most part, she's hovering right around plano. Good endpoints. If we take a look at the topographies, you can see now they look much, much better, both the right and the left eye. If we want to summarize everything on this case, this was the initial CRT design. This was the initial freeform wave design. My first GSIM wave design, and notice my first GSIM wave design was actually better than the initial freeform wave design that was done there. And then of course the final freeform design that I had come up with there, you can see those maps actually look quite clean, quite good, and she was actually very happy with that result. So to summarize the important points from this case, the RX alone made the case look fairly simple. Be wary of asymmetric corneas. Day wear absolutely can interfere with attaining good results. You must keep these people from wearing these lenses during open eye conditions. The solutions play a role as well, and they can interfere with attaining good results. Must differentiate design problems from user error. User error would be in an improper application, improper solutions, improper cleaning of lenses, and the list goes on, including, oh yes, by the way, I have been wearing the lenses all day long during the day because I needed them to see. Freeform design does not guarantee good results and in fact can actually complicate the case. Bad design and treatments do not improve with time. If it's bad from the beginning, it will continue to be bad. Troubleshoot both qualitatively and quantitatively from the treatment topography and the sodium fluorescein at the biomicroscope. And then be patient. Do not rush to make changes. The cornea takes time to take on the proper shape. Remember, error can creep into the data. So if there's error there, you may be making changes on error data. And if it's error data, all the changes you're going to make are going to still result in a bad result. All right. For the private consultation services that I offer 5 options for that. And down in the lower right there, that's the website location where you can find out more about this. But it's primarily for advanced learning, non-FDA approved designs, elevated complexities, and everything that's beyond WAVE's help desk. I offer case-by-case help, which is primarily learn the cases as you go. I'll take care of the case and you'll learn by sitting side by side with me as I take the case, such as was done with this case tonight. Phone help is done through units of time, and that's primarily targeted for learning specific cases or bailing out a case. One-on-one personal time is where I'll do a full day or 2 days fully targeting specific weaknesses of goals and goals of the doctor. Design and supply are primarily for non-wave doctors. That's where I'll do the case and design up a wave lens and supply the wave lens for that particular doctor. And then, of course, there's the recorded DVDs from the Wave Winter Weekend workshop that I had done a few years ago, which is 16 hours of material summarizing really quite a smattering of topics. Wave, Orthok, Scleral lenses, regular corneas. The Wave resource desk has its own help here through the waivers page, clinical support, the concierge lens service, the user guide, the Wave Academy, technical support, and a link to iOS. You have the resource page, which have the recorded versions of these webinars and videos and events that are happening. And of course, there's the online group, the Google group, where topics are discussed amongst all the peers and people who jump in and try and help out. And with that, Carver, I'm going to conclude tonight.
Wonderful. Thank you so much for that presentation. Before we hop into questions, I just wanted to remind everyone that you can ask questions in the chat, though we do have a few waiting. We'll try to get to all of them tonight. The other thing that I would like to remind you all is there is a webinar by Dr. Yandel going over the next generation of the Wave software, which Dr. Mahler has been showing off throughout his presentation tonight. And for any of you looking to understand any of the changes or all of the similarities, I highly recommend checking that out. I believe the registration link is on the Wave website, and that webinar is on March 16th. All right, moving on to questions. All right, so the first question that I have is very straightforward, coming straight from your summary. So how do you prevent, that day wear on patients? Sometimes they just wear it to see better.
Okay, the day wear conversation has to be handled right at the beginning of the case. When you explain Orthok and what you're going to be doing for the patient, and again, this comes up as a bigger issue more for adult Orthok than for kids. But because the kids tend to be a little bit more tolerant and they may not have any issues and they'll be blurry and they'll still adapt through that, whereas an adult has to drive a car and probably has to go to work, and they are very intolerant of blur. Even if the case is directly on target, just that transition at the beginning, they might be a little bit impatient to get to an endpoint where they're very satisfied with the uncorrected vision. And so you really have to have that conversation with them before you start and explain to them that day wearing lens is absolutely counterproductive to attaining our orthokeratology results, period. That's all you have to tell them. You want to see better uncorrected, and I want you to see better uncorrected, and the more open eye wearing you do with these lenses, the more likely we will not get there. And so I lay that out to them before I even order a pair of lenses. If they have concerns about that, as I talked about tonight, what you may want to do is maybe give them a pair of soft lenses to get them through the transition period during day wear if they need them. Maybe make up a pair of glasses of much less prescription and explain to them it's not perfect, but it's something to just help them get by during that transition period. But open eye wearing is absolutely a huge problem for getting to the results you need to, because essentially you're taking a lens that has a treatment zone and smearing it up and down all over that cornea while they're blinking their eyes. No good will come of that. And so when you see maps, kind of like what I had shown tonight, where you see that it looks like it's decentering or it's tilting or something like that, you have to be very suspect that they may be wearing the lens a little bit longer during open eye wear. My instructions to every single patient are, these lenses go on as close to light out lights out as possible. If you absolutely are not shutting the lights off, 15 to 30 minutes of open eye wearing before lights out is the absolute maximum that these lenses can be on during open eye wearing. As far as waking up in the morning, the lenses should be off the eye within 5 minutes of waking up. There is absolutely no reason to leave lenses on. So it's really important to have that conversation before you even start the case, so that they know and understand what their role and their responsibility is going to be to get them to a good result.
Perfect. Thank you for that straightforward set of guidelines. I have a question. Your preference for simpler lens design starting out is well established over these many presentations and webinars that you've done. How much corneal asymmetry would lead you to start with a freeform design?
Well, you can see here, even on this particular case, I was full well aware that we had a fair amount of asymmetry on these lenses, on these corneas from the original topography, and especially on the left one. So I had it in the back of my mind that a GSIM may not be successful on this. Yet I still went ahead and started with a GSIM lens to see what kind of result I could get. And as you saw, my GSIM result really wasn't that terrible. We took care of a couple of things at the same time, meaning the open eye wearing, we got the celluvisc out of the picture. And so some of that may have really derailed my initial GSIM design and made it look a little worse than it actually would have been had we not had those issues as well. But still, I felt that once I saw where that excessive clearance outside the reverse curve in the vertical meridian was occurring, that really wasn't from the celluvisc. Some of it certainly was open eye wearing, but some of it also, particularly you could see how different my superior versus inferior lens ended up being out there, was absolutely due to the asymmetry of this lens, I'm sorry, of this cornea out in the periphery. And so if you took a look there, what did I have? I had, I think, a little over 100 microns of clearance difference between the sags out at probably a chord of about 8 millimeters or so. And that's a significant amount of asymmetry. So this asymmetry of 15, 20, 30 microns, you're making a lens unnecessarily complicated for something like that. A GSIM lens will probably handle that fine.
Great. Honestly, I really enjoyed throughout the entire lecture how you dealt with all of the many confounding complications. I had a question about the oval optic zone, which is how do you determine kind of in more detail how a oval optic zone will improve the fit of a lens?
Well, if you think about what the oval optic zone, oval optic zone is, and I really hate the terminology, and it continues even to this day, that the red ball is the optic zone and the blue ball is the intermediate curve width. They're not. They're control points. It's easier for us to talk in terms of OZ and IC because other lenses are notated that way, and for those of us who've been fitting other lenses, and specifying base curves and OZ diameters and things like that, it's sort of a natural comfort zone for us to refer to those. But in wave, the red ball is a control point. Yes, it has something to do with the optic zone, but not really. We can put that anywhere we want. And in the case of this Orthok case, because of the fact that we have this asymmetry, we had that cylinder where you have that steeper meridian in the vertical, such as we did on this case here, and I had already seen from the previous failures, I had started this case with an oval optic zone with the idea there that I could move the control point in to get the lens to land better, closer toward the apex in the vertical meridian, thus getting the proper seal off out in the mid-peripheral area outside where the blue ball lands. And so the oval zone wasn't so much to deal with the fact that we have refractive cylinder, it was really to deal with the fact that the cornea has a fair amount of asymmetrical toricity. And by creating that toric shape centrally, that allowed me to get the lens to land better, to create a better overall central treatment, as well as a better overall landing outside of the blue ball all the way around 360. And so when you're placing those control points, and in this particular case, they were separated by about 0.6 of a millimeter between the horizontal and vertical, where that all came from was really from my analyzing what the elevation differences look like on that particular cornea so I can get this lens to land properly. It is wrong to think that you just, because the patient has a refraction of -3, -2, axis 180, just make an oval zone and that'll fix all the evils of that particular case. What you really have to do is look at the differences of elevation on that particular cornea in its virginal state, and then decide if you really need a sort of a smaller treatment zone along that steeper meridian so that you can get the lens to land better. So that's really where the criteria for that oval zone comes from.
Perfect. That is a wonderful explanation of all of the kind of steps you took with that optic zone. Thank you so much. I have one final question for you tonight.
Sure.
All right. Do you have any additional information on how the solution used when wearing the Ortho-K lens affects the results?
That we can make a whole webinar on that one. Solutions are incredibly important because if I had to pick the single parameter that makes me shudder when I have to take on a case, it has to do with absolutely a horrible tear film. It's not high RXs, it's not cylinder, it's not oblique elevations, it's not even asymmetric corneas. Horrible tear films make me shake. And the reason they'll make me shake is because you can have a 2-diopter sphere and it still becomes an impossible case because the tear film does not allow the case to go to success. And the reason for that has to do with the hydrodynamic forces that are created underneath the lens, between the back surface of the lens and the front surface of the cornea. And so things that alter tear chemistry, and just think about this for a second. We design wave lenses down to a precision of hundreds of a micron of curvature, and then we put in glops of celluvisc that are so thick that no matter what you designed on the lens, the cornea actually never even sees that because there's so much thickness between the back of that lens and the front of that cornea. So the solutions that you choose need to be consistent from case to case so you can start to see what solutions will work for you, as well as you don't really want to alter tear chemistry. Now, if in fact you have a very dry eye, and again, this doesn't come up as much with the younger population that are going into Ortho-K. Most of the kids have such robust tear films that this is a non-issue. But when you're doing adult Ortho-K, we do know that the tear film absolutely becomes more compromised as we age, and these can be real problem areas for us. And so one of the criteria, and you saw me even on this particular case, when I summarized the case right at the beginning when I first started it, my first question sort of out loud to myself was, that tear film looks a little questionable. I wonder if that's going to be a problem for us. So that's the place where you need to start. And then if you have a tear film that looks questionable, you might even want to try and improve the tear film before we even start Ortho-K, because that'll make your Ortho-K case go more successfully. Once you've started your Ortho-K case, you obviously have to maintain a good tear film so you can create those proper forces underneath that lens, that correct push-pull everywhere underneath that lens, and so it seals off properly. The idea of using thick solutions to mask bad design errors, I think is a really poor approach. Make a proper design, use a thin tear film agent to fill the lens. I start everyone with preservative-free saline, Lacropure. Actually, Lacropure is almost hands down 100% how every one of them start. And then if I see I have problems, then I will start, just like with the dry eye therapy, start adding in one thing to change, another thing to change, and another thing to change, so that we can start to build up a better tear film if I see, in fact, that the design is good, but the tear film is really where the problem is with the case. So the solutions chosen, I think, are very, very important. Everything that goes on the surface of the eye that can alter tear film is a potential derailer for your case. And so these are the things that you have to keep sort of tabs on, because certainly the more novice ortho K doctor would take a look at something and say, where you have a bad treatment topography and say, oh, I have to change the design of the lens, when in fact the problem really is all sitting in the tear film, and it's possibly that it's just not a healthy enough tear film to support that lens. So it's really important to sort of differentiate where the problem is coming from. Is it a design problem, or is it something else? And if it's something else, all the redesigning isn't going to fix the problem. So that's really the crux of the matter, is correctly identifying where the problem's coming from. And if it is not design related, don't change your design. Start managing the case elsewhere. And some of it may take a little trial and error. I can tell you I had a fellow in orthokeratology starting at the age of 62, 63. He had never had contact lenses, horrible tear film, had a pterygium on the eye as well. And I knew the tear film was going to be a big problem right from the start. And he was a man, which makes him even more difficult to learn the logistics of getting a lens on at 62, because he had never had any contact lens history. After several different avenues that we had experimented with, he and I came up with the proper recipe of exactly what he had to put in his lens, which was 1 drop of Refresh Plus, 1 drop of saline, then put the lens on, put another drop of Refresh Plus into his eye after the lens was on, and then go to sleep. And then we ended up with fantastic results. So sometimes it does require a little bit of trial and error to find out exactly what's going to work, but be very careful and very leery of sort of putting in very, very thick agents under a lens that you've taken the time to design all these meticulous curves on, because you don't actually know what you're really treating at that point.
Perfect. All right. That was a great kind of explanation of the really severe impact and kind of confusing effect that a thick solution can have on the result of your lens fit. That is the last question we had time for tonight. But I want to thank each and every one of you on behalf of WAVE for attending tonight. And Dr. Muller, I want to thank you for your presentation.
You're most welcome, Carver, and thank you all for coming out and listening to this one. And like I said, next month we're going to be looking at troubleshooting before the case even starts. And so I hope to see you all next month.